Say goodbye to the overwhelming maze of treatment options for your running injury. This video will take the guesswork out of finding the best solution. Because when you're injured, your therapist can suggest massage therapy, dry needling, and acupuncture. Yes, they are two different things. Joint manipulation, shockwave therapy, therapeutic ultrasound, trigger point release, and even injections. Don't let confusion and frustration hold you back as we kick off step 7 of this 10-step rehab journey and getting you to rethink the way you think about rehab. And in this video, you're not just taking my word for it, because I have some bonus content at the end from one of the world's best tendon researchers talking about the effectiveness of the options I listed earlier. Hopefully by now you've watched the first 6 videos and are starting to rethink your rehab approach and feeling more in control of your destiny. If this is the first time you're hearing about these 10 steps, up top is the link to take you to the playlist, which will take you to step 1. Now, the past few steps have talked about assistance from a therapist and how to troubleshoot setbacks in your recovery. Naturally, if you seek extra assistance, these hands-on or passive treatment options may be offered to you. But Brody, how do I know which treatment method is right for me? Good question, but the answer might surprise you. Because research will almost always place passive treatment as a secondary option in the treatment of overuse injuries. What is the primary method of recovery? Well, it's the steps that you've been learning so far, essentially strengthening the injured area and the surrounding joints with active rehab. This approach raises the overall capacity of the injury so it can better withstand the forces required for running and other activities. Take this paper from Collins and colleagues, which is a systematic review on the treatment of runner's knee. And the number one recommendation they list is exercise therapy to reduce pain and improve function in the short and long term. It is only down at recommendation number 3 that they recommend manual therapy to reduce the pain in the short and medium term, only provided that it is combined with exercise therapy. Furthermore, the use of joint mobilizations are not recommended in isolation, and electrophysical modalities such as therapeutic ultrasound is not recommended in any circumstance. I think this hits the mark for most running related injuries. And let's simplify it with my own rules. Rule number 1, exercise therapy such as progressive rehab is a must. Number 2, passive hands-on therapy can be used to reduce pain in the short term if you personally find benefit. In other words, if you don't have a noticeable reduction in your symptoms shortly after treatment, there's no point really doing it. And the only way you can know if it is beneficial is through trial and error. Unfortunately, 10 runners can have the same injury and vary wildly in their responses to different treatment methods. So when I treat a runner online who's also having manual work done by their local therapist, I ask of its effectiveness and how long the effects last, and have them decide if it's worth continuing or not. If you can find a method that does temporarily reduce symptoms, you can use this in combination with exercise therapy to accelerate the rehab process. My third rule is, once you have found a method that is effective, recognize that it is just a short-term fix. Trust me, I've seen injured runners get 20 shockwave sessions or have 15 dry needling sessions without the sense of improvement. Don't buy into these types of recovery plans. In addition, the longer you've had the injury, say if you've had it for months or even years, manual therapy may become less relevant. Let's use Cody as an example. After recovering from his flare-up plan in step 6, he's now back to running and strength training within acceptable pain limits. But he isn't symptom-free either. So he calls around and tries out joint mobilizations, he tries dry needling, and he doesn't notice any benefit. He then tries some massage therapy around his quads and notices an improvement which lasts about 2 days. He decides to implement this treatment 1 to 2 times per week for the next 3 weeks. And as a result, he's able to progress his rehab ladder more effectively. Once he's symptom-free, he maintains the progressive rehab, but weans off the massage. Why am I highlighting these rules? Well, I've seen injured runners unknowingly get sucked into passive treatment traps where they pay for 1 to 2 sessions per week for months, see a small improvement momentarily and never see long-term improvement. Even worse, some runners can become more reliant on a particular therapy as their treatment cycle continues. Think of someone who has their pelvis manipulated because they're told that it's out of place. They feel great afterwards, but it's short-lived. And when the pain returns, they think their hips are again out of place and need another adjustment. And over time, the treatment becomes less effective and weans off quicker, and the runner is convinced they need to do it more often. And the treatment cycle continues. I've seen runners get adjustments several times a week just to feel normal, so don't get into this trap. The same storyline can happen for massage, can happen for trigger point release, for dry needling and other passive treatments. Not only does this recovery roadmap not have a long-term trend, but it's also really disempowering and is giving 100% of the control into the therapist. Ideally, you want to be in control of your rehab and play an active role. The therapist should be in the back seat and provide the roadmap if needed, but you need to be in the driver's seat. Okay, Brody, I get the point about manual treatment, but my medical team is also suggesting injections to help with my recovery. What should I do? Firstly, since every injury is unique, I don't know your unique circumstances, so stick to the medical advice given to you, or you can book in an injury chat with me and we can chat further. But when it comes to injections such as PRP and corticosteroids, you do need to know the facts. In the case of tendon injuries, I had the privilege of chatting with Peter Maliaris, one of the world's best tendon researchers on the Run Smarter podcast. And this is what he said.
The key to management of a tendinopathy is good progressive exercise to bring about tolerance of the tendon, as well as good education to couple with that and not overdoing it with things that can aggravate. And if you scratch the surface below those things, to all the adjuncts like shockwave and injections and surgery and everything else, the evidence is really, really poor. For any treatment, we need to know whether it works over and above placebo. If you compared, as some studies have, PRP to steroid, in the long term, a lot of those studies have shown that PRP is better. But that's probably because steroid is harmful in the long term. So you need to be very careful of the comparison, and placebo comparisons for things like this are really important, I believe. We need to know whether they work over and above doing something like a placebo, which controls obviously for the placebo effect. We just don't have that evidence for anything convincingly in tendinopathy, aside from it could be argued exercise is the only thing that we can say, okay, there is, this probably does do something.
At the very least, I would recommend 3 solid months of tailored progressive strength training of your injury, such as following every step in the 10-step journey before even considering injections. And that isn't just having 3 months of pain either. That is 3 months from implementing a good management. We're almost up to step 10 and completing this series. If you're still not making any significant progress, it's time to cover my best rehab troubleshooting tips.